Welcome to MedEd's production of the Cardiac-Vascular Nursing Exam Review. My name is Klacman, and the title of this module is Valvular Heart Disease. So on the exam, you're going to have a couple of questions related to valvular heart disease and how you manage those patients. Most of those questions are going to be related to left-sided valve disease versus right-sided valve disease. So we're really going to spend time here focusing on left-sided valves versus the right-sided valves. So when you're auscultating heart sounds, and this is very telling because on the exam they may tell you that you're hearing a sound at the second intercostal space, right sternal border, and that would help you then decide, well, what valve may be involved. So the second intercostal space at the right sternal border is where you're going to hear aortic sounds. Okay, second intercostal space, right sternal border. Second intercostal space at the left sternal border is where you're going to hear the pulmonic sounds. Okay, now that doesn't make a lot of sense because the pulmonic valve sits on the right and the aortic valve sits on the left. But if you think about the way blood comes out of the heart, that makes a little bit more sense. That blood from the left ventricle goes more up towards the right, and blood from the right ventricle goes more over to the left. So that's why you hear those sounds there. The atrioventricular valves, okay, the tricuspid and the mitral valve, those sounds are going to be heard down at the fifth intercostal space. So you're going to hear the tricuspid sound at the fifth intercostal space, left sternal border, and you'll hear the mitral sound at the fifth intercostal space at the left mid-clavicular line. Okay, so if you find the mid-clavicle on the left and drop down to the fifth intercostal space, that's where you're going to hear the mitral sound. So now we're going to talk about the different abnormal heart sounds. So you have S1 and S2. Right, and that's the normal lub-dub, lub-dub. Now S3 and S4, okay, you may see these on the exam and they may give you a clue as to what's going on with the patient. So both of these sounds occur during ventricular diastole, when the ventricle is filling with blood. One of these occurs in early diastole, and one of them occurs in late diastole right before systole. Okay? Now, the way that I think about this is which of these numbers occurs earlier in the number line. Okay? It's 3. So when S3 is heard in early diastole, and S4 is heard in late diastole. Okay? Now, if you think about the filling of the ventricle, remember that there's two phases to the filling of the ventricle. Okay, there's a passive phase where the tricuspid and the mitral valve open and blood rushes into the ventricle. And then there's an active filling phase of the ventricle where the atria are contracting and contributing their extra blood volume into the ventricle. So an S3, all right, associated with early diastole is associated with passive ventricular filling. And an S4 that's heard in late diastole is associated with the active filling phase of the ventricle when the atria are contracting. Okay? So an S3 sound occurs with a highly compliant left ventricle. That's a left ventricle that is ballooned out. All right, it's thin. It's a large chamber, and so in that situation, we would start to think about systolic heart failure, or heart failure with a reduced ejection fraction, where you've got blood moving into a dilated, ballooned out ventricle. And then an S4, because it's heard in late diastole and occurs with active filling of the ventricle, well, here you would want to think about that being where you've got the atria contracting against a very stiff, non-compliant left ventricle. So you would hear this in situations where patients have left ventricular hypertrophy, where the ventricle is subject to pressure overload. So conditions of heart failure with preserved ejection fraction. Okay. Now both of these sounds can be heard during an MI. Okay. Typically in the early phases of an MI, when the heart is not contracting well, you're probably going to hear an S4, okay, because the ventricle is not contracting, okay? And then as the patient develops heart failure, if they've had a bad enough MI, then you'll hear an S3, all right, as that ventricle can no longer pump the blood that's moving into it. Now, when we talk about valve disease, there are two different things that can happen with the valves. Valves can become stenotic or valves can become regurgitant. So when valves are stenotic, there is a narrowed path for blood to move from one chamber to the next area where it's supposed to flow to. Okay, so there's restriction to forward flow. So with a stenotic murmur, you're going to hear that when the valve is supposed to be open. Okay, so stenotic murmurs you're going to hear when the valve is supposed to be open. Okay, so if you think about when the aortic and the pulmonic valves are supposed to be open, well, those are open during systole when we're trying to get blood from the ventricle out into one of the circulatory systems. Okay, so you will hear the murmur of aortic stenosis and pulmonic stenosis during systole. Okay. And then when you think about when the mitral and the tricuspid valves are supposed to be open, and those valves are typically open during diastole. All right, so you will typically hear the murmur of mitral and tricuspid stenosis during diastole when those valves are supposed to be open. Now, whenever a chamber of the heart is having to pump up against a high pressure, that's going to result in a pressure overload, and the chamber that pushes into that valve is going to hypertrophy. Okay, so if a patient has aortic stenosis, we are going to look for signs of left ventricular hypertrophy because that's the chamber that pushes through the aortic valve. If a patient has pulmonic stenosis, well, then we're going to look to see if that patient has right ventricular hypertrophy because that's the chamber that's pushing through the pulmonic valve. Okay. And then for mitral and tricuspid stenosis, we would look for atrial hypertrophy. If the patient has mitral stenosis, we're going to look to see whether or not the left atria is hypertrophied. And if the patient has tricuspid stenosis, well, then we're going to look to see if the patient has right atrial hypertrophy. Now, regurgitation. So regurgitation is where you've got a floppy valve, it's incompetent, and there's the backflow of blood right back into the chamber where it just came from. Okay, so the murmurs here are going to be best heard when the valve is supposed to be closed. Okay, so stenotic murmurs we're going to hear when the valve is supposed to be open, and during regurgitation we're going to see that we're going to hear murmurs when the valve is supposed to be closed. Okay, so again, we talked about this earlier, that everything in the heart is just opposites. So if my aortic and pulmonic valves are open during systole, well, then that means they have to be closed during diastole. So we would hear the murmurs of aortic and pulmonic regurgitation during diastole. Okay? And then when the tricuspid and mitral valve, all right, are supposed to be open during diastole, okay, well, that means that they are closed during systole. Okay? So we would expect to hear mitral and tricuspid regurgitation sounds during systole. Okay? And regurgitation of valves always results in volume overload, and dilation of the chamber where the blood is regurgitating to. So regurgitant valves will typically lead to heart failure with reduced ejection fraction, whereas stenotic valves will typically lead to heart failure with a preserved ejection fraction. So in aortic regurgitation, I always think about where blood is flowing through the aortic valve. It's from the left ventricle out into the aorta. So if the aortic valve is regurgitating, then we would expect that blood's going from the aorta back into the left ventricle during diastole. So in this situation, we're going to see left ventricular chamber dilation. And same for pulmonic regurgitation. Okay? Normal flow through the pulmonic valve is from the right ventricle to the pulmonary artery. And so when that valve is regurgitating during diastole, you have the flow of blood from the pulmonary artery back into the right ventricle. Okay? And then with mitral regurgitation, I think about how blood normally moves to the mitral valve, and it's from the left atrium down into the left ventricle. And so if the mitral valve is regurgitating, that's going to occur during systole, where you have the backflow of blood from the ventricle back up into the atrium. And so during mitral regurgitation, you would have left atrial chamber dilation. And during tricuspid regurgitation, you would see right atrial dilation. Make sure that you understand grading of murmurs. And the way that I always think about these is there's 6 different grades of murmurs. Okay? The first 4 you're going to hear with the stethoscope on the chest. The last 2, grade 5 and 6, you're going to hear with the stethoscope off the chest. So on the exam, if they tell you that you're hearing a sound with the stethoscope on the chest, we know that that's at least a grade 1, 2, 3, or 4. If you're hearing it with the stethoscope off the chest, we know that's at least a grade 5 or 6 murmur. Okay, so sometimes that will help you. So make sure to understand the grading of these. A grade 1 murmur, barely audible in a quiet room. Okay, really would take an experienced cardiologist to hear that. Okay, grade 2, quiet. It's readily heard when the stethoscope is on the chest. Grade 3 is a moderate intensity. Grade 4 is loud, where you've got a thrill with it. And then, of course, grade 5 and 6 is where you can hear it with the stethoscope off the chest. Okay? Now, I would make sure that I understand this table up here, because this is a summary table of your murmurs and where you're going to hear those sounds, okay, and the locations of that. So make sure that you read this table up here and understand it, okay? Now, with aortic stenosis, all right, there are 2 reasons that patients can develop aortic stenosis. They can have a congenital problem with the valve, where there's an abnormal valve structure, okay? And so typically symptoms are going to appear earlier than you would if you've got some acquired condition. So if you've got a congenital defect, typically between 40 and 60 years of age, you're going to start having symptoms of that. And then with an acquired condition, most of the time this is due to some condition that the patient has developed after birth, rheumatic heart disease. We don't see that a lot anymore, but if you've got a patient that's old enough, they could have aortic stenosis from rheumatic heart disease. Biggest reason for it is calcification on the valve. All right, so if they've got hypercholesterolemia, if they've got, again, all of the risk factors for cardiac disease, they could have calcification of the valve, and that's an acquired condition. And so typically patients aren't going to show signs of that until much later on, typically after the 7th decade. Now, it doesn't matter what the cause of aortic stenosis is, all right? It causes the same problems within the heart. So this picture that you're looking at up here is a normal left ventricle, and you can see your pressures. So the pressure in the left atrium is about 10. Pressure in the left ventricle, systolic over diastolic, 120 over 10. And then the pressure as you come across the aortic valve is 120 over 80. Well, what you'll notice is in aortic stenosis, the first thing that happens is blood has a hard time flowing across that valve. And so you'll notice here that you've got a drop in your systolic blood pressure and your diastolic pressure. Okay, so these patients who have aortic stenosis typically are going to have signs of hypodynamic circulation, low cardiac output, weak pulses. They're going to show signs of hypodynamic circulation. Okay, well, you'll notice that over time what ends up happening is that ventricle becomes really thickened, hypertrophied, all right, so that it can keep blood moving across that valve. All right, and so what you'll notice is that this patient has developed heart failure with a preserved ejection fraction. They've got diastolic failure, okay? And then over time, what will end up happening is that pressure in the left ventricle is going to back up now into the left atrium. And the left atrium is not going to be able to send all of its blood down into the left ventricle. So the left atrium is going to dilate all right, and it's going to have to hypertrophy in order to send the blood down into the left ventricle. Now, most patients, again, don't develop signs of aortic stenosis for decades. And unfortunately, once most patients start having symptoms, their average survival time is less than 5 years. Now, there's a triad of symptoms that patients are going to develop when they have aortic stenosis. And again, once these symptoms start, they are typically dead within 5 years if they don't receive treatment. So the way that I remember this, triad of symptoms is, I think, ASH, A-S-H. Patients are going to develop angina, especially with exercise, because if that aortic valve is thickened, you're not going to get blood flow past that valve, and you're not going to perfuse your coronary arteries, which sit just past that valve. In addition, if that valve is thickened enough, it could cover over the coronary arteries, and you may not get flow. Okay, so that's the first symptom, angina. Then from there, patients will develop syncope or fainting. And then lastly from there, the last symptom is heart failure. And once they've developed heart failure, it's about 2 years, all right, and then they will die if they don't do surgery or intervention to fix the valve. So the way that we medically manage these patients is you want to have heart rate and you want to have rhythm control. When a patient is tachycardic, remember, okay, and their heart rate's high, that decreases their diastolic filling. All right, so in that situation, you are going to further drop the amount of blood that's able to come out of the left ventricle across the aorta, so you can make their condition worse. Now, there is some indication for the use of medications that cause peripheral vasodilation to try to help vasodilate past the aortic valve and get better blood flow. And so you can use medications like ACE inhibitors, nitroglycerin, things that cause vasodilation. And then if they've got some kind of calcification on the valve, well, then you may want to put that patient on a statin medication and treat hypercholesterolemia. Now, surgical management of these patients. All right, so one of the biggest things that started happening here is, if you look at the recommendations, really surgery was for those patients who were at a low to an intermediate risk of having problems, okay? That they were going to be alive for longer than about 12 months, okay? And then those would be your patients that would go to the OR for surgical management. Okay. If you were not a surgical candidate, you had a high risk, or you had less than about 12 months of survival, even if they did a valve replacement, well, those are the patients that they save for TAVRs or trans-aortic valve replacements. Okay. Now, in terms of surgery, there are 2 different types of valves that patients can get. Okay. And it's really kind of 6 of one, half a dozen of the other on which one of these you want to get. All right, because both of them have complications. Now, mechanical valve works really, really well, especially for younger people. All right, because that valve is going to last for a long time. Okay, it's a mechanical valve, it's going to last. The problem with it is that patients are going to have to be on anticoagulation for the rest of their life because there's a high risk for blood to clot on that mechanical valve. Whereas biological valves are typically used more so in patients who are older, because those valves will typically start to fail after about 10 to 12 years. Now, the nice thing about those is that even though they may fail and you have to have it replaced, well, you're not going to be on anticoagulation for the rest of your life because you've got a biologic valve. So again, mechanical valves typically for younger patients, biological valves typically for older patients, you know, who may have 10, 12, 15 years to live. Now, the transcatheter aortic valve replacement, the TAVR procedure. Now, this is a procedure that is used in patients who have a high surgical risk for aortic valve replacement. They typically have multiple comorbidities, they are very ill, and they probably, even if they get a TAVR, are not going to survive much longer than a year. Now, what happens in a TAVR is they are going to thread a catheter up through the abdominal aorta, up through the descending aorta, across the aortic arch, and they're going to seat it across the old aortic valve. They are then going to do a balloon valvuloplasty, and they are going to fracture anything that may be on that valve, the native valve. And then they are going to seat a prosthetic valve, typically either a Sapiens valve or an Evolut valve, across the old aortic valve. And then they're going to remove the catheter, and you've got a new valve sitting there. The problem with these is there is a high risk for stroke development, especially when they are fracturing anything that may be sitting on that valve, because it has a chance to emboli, to turn into an embolus. And unfortunately, if it's calcium or something else, that patient is not going to be a TPA candidate, because TPA doesn't work on calcium emboli. Okay, so if they have a stroke because of this, well, they're not going to be a candidate for TPA. Now, one of the things that's really started to happen is looking at actually doing TAVR patients in patients who are less sick and have a longer life expectancy. And so there are places now that are doing studies on this, looking at actually doing TAVRs instead of taking patients to the OR and doing an aortic valve replacement. And it's showing that it has a high success. But the problem with it is the companies that manufacture these valves don't know exactly how long they're going to last. All right, they've only, again, patient average life survival with them is a year or two. Okay, so they don't know how long these are going to last long term. Okay, so more research to come on that. And then there's aortic regurgitation. So again, two different major reasons that patients can develop aortic regurgitation. There's chronic conditions, okay, that can be congenital, or they can be acquired, where patients have endocarditis, different conditions like that. And then it can be acute from trauma, acute aortic dissection, so different reasons for aortic regurgitation. Now, in aortic regurgitation, instead of being subjected to a pressure overload, like in aortic stenosis, in aortic regurgitation, the ventricle is subject to a volume overload. So as the ventricle is in diastole, you're going to have blood regurgitating from the aorta back down into the left ventricle. Well, in addition to that, during diastole, the atria is trying to fill the ventricle. So in aortic regurg, you have blood coming back into the ventricle from two places during diastole, okay, from the aorta and from the atria. And so that causes a volume overload on the left ventricle. And so what you'll notice here with aortic regurg is now they have a lot of volume. And so these patients are going to develop signs of hyperdynamic circulation. So they're going to be pink, rosy, they're going to be really nice looking, have a great blood pressure. In fact, one of the things that you'll see is a widened pulse pressure in these patients. So if you look over on the left at a normal heart, you'll see that the pulse pressure in the aorta is 120/80, and that's 40, and that's normal. But if you look over at the heart that has aortic regurg, their pulse pressure is 160 minus 60, and that's 100. So they have a widened pulse pressure, okay? So they've got extra flow, hyperdynamic circulation. So some of the signs that you will see of aortic regurgitation is you can start to see signs of dyspnea, paroxysmal nocturnal dyspnea, orthopnea, different things like that, because as the aortic valve is regurgitating, well, that blood's going to be transmitted back up into the left atrium and then to the lungs. So some symptoms that you may see from this: warm, flush, reddened membranes, wide pulse pressure. De Massé sign is head bobbing, and if you watch these patients very carefully, you will notice that with every beat of their heart, their head is bobbing up and down. Sometimes it's very subtle, but you can see that happening. Corrigan's pulse is a large pulsation in the neck and the carotid artery. It's kind of where their carotid artery is just pulsating. And then Quincke's sign is where you've got non-blanching okay, you've got pulsatile blanching of the nail bed, okay, all right, when light pressure is applied. Typically, that should turn white, okay. Well, if it doesn't and it stays red, then that would suggest that there's hyperdynamic circulation. Okay. Management of aortic regurg depends on whether or not it's acute or chronic. And in chronic aortic regurgitation, patients may not require a whole lot of treatment. Now, one of the things that you can use in these patients sometimes is arterial vasodilators, right? Because if you put somebody on a vasodilator, that's going to decrease their afterload, and that'll decrease the regurgitation from the aorta back into the left ventricle. You also want to try to get any fluid off of this patient if their lungs are filling with fluid, so diuretics, okay? You want to try your best to avoid arterial vasoconstrictors because that's going to make the regurgitation worse. And then in addition to that, it can also lead to stenosis if they are severely vasoconstricted. And intra-aortic balloon pump is contraindicated in all aortic regurg patients. Should not ever be used. Now, in an acute situation, you want to get a stat echo, and this is typically where the patient's going off for emergency valve replacement surgery. If they are in cardiogenic shock, you're not able to get them to the OR. Well, in that situation, then you may need to do some things in the ICU to stabilize them, inotropes, reduce their preload. So this is a patient that's in cardiogenic shock. And you absolutely want to avoid use of the intra-aortic balloon pump in acute aortic regurg. It'll make their condition drastically worse. Management of these patients in terms of surgery is the exact same as it is for aortic stenosis, all right? They can either have a valve replacement in surgery or they can have a TAVR done to replace that valve. And then mitral stenosis. So mitral stenosis is actually pretty rare. Patients that develop mitral stenosis, one of the biggest places where you would see that is in rheumatic heart disease, right? When patients would develop rheumatic heart disease, then it would cause problems with the valves. There are some congenital problems that can happen with the mitral valve. They can have atrial myxoma, lupus can cause that, and then bacterial endocarditis. And so what happens in mitral stenosis, again, is the left atrium is having a hard time pumping against that stenotic mitral valve. And so the left atrium is going to have to hypertrophy, right, in order to push that valve open. Well, because the mitral valve is stenotic and the left atrium is having a hard time opening that valve up, that's going to decrease the flow into the left ventricle, and it's going to decrease the flow across the aorta out into the body. And so you'll have a small drop in your blood pressure. So these patients may have narrowed pulse pressures, okay? Right, they may have a narrowed pulse pressure. And then because the left atrium is failing, well, then that's going to back up into the lungs, and your patient may have signs of pulmonary edema, respiratory distress, different things like that because of the high pulmonary vascular pressures. So symptoms, biggest symptoms in mitral valve disease, whether it's mitral stenosis, mitral regurg, is dyspnea and problems breathing. Okay, it doesn't matter whether it's mitral stenosis or mitral regurg, both of those patients can develop dyspnea and have problems breathing. And because the atria are being stretched, these patients are at a high risk for the development of atrial fibrillation. Okay. Medical management of these patients, beta blockers, calcium channel blockers, you want to try to get their ventricular rate down, and if they have AFib, cardiovert that. Okay. You want to try to decrease preload with sodium restriction and diuretics so that you can get the fluid out of the lungs. Right? You don't want their lungs filling up with fluid, so sodium restriction and diuretics work really well. And then they're at a high risk for clot development if they have atrial fib. So if they do, anticoagulation. They need anticoagulation. Now, the couple of ways to manage mitral stenosis. They can do mitral balloon valvuloplasties, where they bring a balloon across the mitral valve, open it up, fracture anything that may be on that valve in terms of calcification or anything like that. or they may need to go in and do a complete mitral valve replacement. Okay. Mitral regurgitation. So in mitral regurgitation, again, there are certain structural abnormalities that patients can have that cause them to have problems with the mitral valve. You can have congenital problems, rheumatic heart disease again, endocarditis. Patients who have collagen vascular disorders like Ehlers-Danlos, Marfan syndrome, different things like that, those patients can develop mitral regurgitation. And then you can have functional changes as well. That can lead to that. If you have papillary muscle rupture, different things like that, where one of those valves becomes completely floppy. Now, mitral regurgitation pathophysiology is very similar to what happens in in mitral stenosis. Again, the mitral valve here so the mitral valve is regurgitating, so you're going to have the blood flow back up into the left atrium from the left ventricle. Because that left atrium is holding more blood, it's going to dilate, the chambers are going to become weak, and ultimately it's not going to be able to pump blood, so you're going to get the backflow of blood here into the lungs. So these patients, again, can have respiratory distress, pulmonary edema, different things like that. Okay. All right. So if it is an acute condition, all right, patients' hearts are not going to have time to compensate for that. Okay, so if you have somebody that has acute mitral regurg because they have a ruptured papillary muscle that's torn away from the heart muscle, right, in those patients, they're going to wind up in cardiogenic shock very quickly. All right, so in those patients, you need to get them to the OR, fix whatever the problem is. Okay. So again, mitral regurgitation, usually no specific treatment required if you're asymptomatic. Again, because the atria are involved in this, if there's atrial stretching, patients can develop atrial fibrillation. So if they are in AFib, get their rhythm under control, possibly rate control, anticoagulation, and then sometimes ACE inhibitors work as well in these patients. So let's look at some review questions here. So the intensity of a murmur that is loud and can be heard with the stethoscope lifted off the chest and accompanied by a thrill would be classified as the best answer here, grade 5. So remember, grades 1, 2, 3, and 4 are heard with the stethoscope on the chest. So the one up here where it's lifted off of the chest would be grade 5. The cardiac-vascular registered nurse is reviewing the cardiac patient's history. In the chart, there is mention of a murmur of mitral valve stenosis. When auscultating the heart, the nurse would pay particular attention to which area? So the best answer here is 5th intercostal space at the left midclavicular line. Okay, that's where you're going to hear the murmur of mitral valve stenosis. And the last review question, the cardiac vascular registered nurse is assessing a patient and notes an S3 heart sound at the 5th intercostal space at the left midclavicular line. The nurse would expect what finding on the echocardiogram? And the best answer here is B. So this is a question that if you look at it very carefully, you will notice that there are 3 answers here that are very similar that cause the same things. And then there's one condition up here that's drastically different. So if a patient has aortic stenosis, that will lead to left ventricular hypertrophy. Okay? And then if I have a calcified aortic valve that's hard to open, well, that will also lead to left ventricular hypertrophy over time. So there's 3 of those that you can do away with, and there's one of them that's the correct, that's different than all of the others, and that's left ventricular chamber dilation. So again, remember S3 heart sound associated with a highly compliant, ballooned out, dilated left ventricle.